discernment as we work through these issues. May everything we say and do be pleasing in thy sight. In Jesus' name, amen. Shelley, roll call, please.
Yes, sir. I will have to do 2 roll calls again today. One for those that weren't in an election, one for those that were. Those of you that were in an election, I need to know if you want to be a member of the committee as well. So, Mike Dobbins.
Here.
Dora Petzkowski.
Here.
Keith Austin.
Here.
Julia Coates.
Here.
Sean Crittenden. Joe Deere. Rex Jordan.
Here.
Darrell Legg.
Here.
Wes Snowfire. Danny Callison.
Here. Yes.
Johnny Kidwell.
Here. Yes.
Joshua Sam.
Here.
Mike Shambaugh.
Here. Yes.
Melvina Shotpouch. E.O. Smith.
Here. Yes.
Condessa Teehee. Victoria Vasquez. We have a quorum.
Okay, thank you, Shelley. We have the minutes that are in your packet, both from Last Health and also from Public Health. I would entertain a motion to approve both of those. All those in favor? Aye. Any opposed? Thank you. We're dropping down to reports. Our first one is from the IHS Claremore Service Unit, Mr. George Vallier. George.
Good afternoon.
Hello, George.
I think you have my report there in your packet. There were a couple of questions asked the last meeting. There was one about are we testing variants at the hospital? We aren't doing any variant testing there at the hospital. We do send everything to the state so that they can test variants, but we're not getting we've not gotten any feedback, any results back from them since this has started. So the best answer to that is no, we aren't testing for variants. And then there was another question about children under 12 with COVID that were positive that needed hospitalization. Were we keeping them or transferring them? If we have a 12-year-old, any pediatric patient that requires hospitalization for COVID, they're transferred out. The report that you have in your packet is for July. The month of July, we're always a month behind. For July, we tested 1,482 patients, and out of that, 919 were Cherokee citizens. And out of that 919, 184 were positive. That month we had 381 patients in dental, performed 3,284 procedures. We saw 2,183 patients in the lab, performed 43,296 different tests. And for that month, pharmacy filled 29,626 prescriptions in the outpatient pharmacy. Our collections are good. Our collections are up. People are coming back to the hospital. We're testing out front daily. We're giving vaccines inside the hospital and in the different clinics. We've got monoclonal antibodies going when we have eligible folks that want those. We're gearing up for flu season. So as soon as we get our vaccines in, we'll get the flu vaccines kicked off. Are there any questions?
Questions for George? George, would you explain a little bit about the number of shares that the Cherokee Nation has with the Claremore Service Unit? The tribes have different shares Can you explain that a little bit?
I'll give you a very brief explanation as far as I can here. When I talk about shares, is how much, what funds are in our service unit. And I think what you're referring to is the Creek Nation's taking all of their funds out. Up until that point, it was kind of just a general rule of thumb that Cherokee Nation had about 60% of the shares left in Claremore. There are the tribes up in the northeast corner, the Northeast Consortium still have shares there. Tulsa Urban still has shares there. But since they've taken theirs out, I don't have an exact number. All that information is taken care of and kept down at area office. But just kind of as a rule of thumb, up until this point, Cherokee Nation has had about roughly 60% of these shares in Claremore.
So with the Creeks pulling their shares, you still need to treat those Creek patients even though they pulled their shares, so to speak?
Yes, sir. We're not allowed to not see a federally recognized beneficiary. Yes, that's correct.
So when you say the Cherokee Nation has roughly 2/3 of the shares, does that mean 2/3 of your caseload is roughly Cherokee? Is that?
That's pretty close. That is pretty close.
So if we have a Cherokee that wants to get services at the Claremore Service Unit, do they have to establish a new chart? They can't use the chart that they have within the Cherokee system. They have to establish a new chart with the Claremore unit.
Yes, sir, that's correct. They'll come up and start a chart there. Now, one of the things we started several years ago was because there are Cherokee Nation folks who don't come to Claremore, but they live in our contract health area. If they're referred out, they don't. In the old days, they were made to come to Claremore physically and start a chart before they were ever considered for that contract health service. Here, what we've done in the past few years is if the referring clinic, Cherokee Nation Clinic, will fax their eligibility information with the referral, we'll go ahead and get that chart made so there's no delay in care for that patient. Excuse me. So we've tried to help like that so that they don't have to come start that chart.
Okay, thank you, George.
Mm-hmm.
Questions for George? Just as a quick note, I think probably all of us know this, but if you have a Cherokee that has a chart in Oshaleta, that chart is good in Muskogee or Tahlequah. The chart is good across the 14 counties, all the clinics. If they have a chart in Jay, then they have a chart in Tahlequah. It's in the system. So that was good information about those that wanted to go to Claremore.
Yes, sir.
Okay, George. Oh, Daryl, I'm sorry.
How you doing, Doc? Do y'all get the majority of cancer patients at your clinic?
No, just what comes in.
Okay. Do y'all, when you say contract health service area, is that within the 14 county jurisdiction? Do they have to reside?
You just opened up a whole complicated can of worms there. Contract health you'll learn is probably one of the most complex entities in our health system. Our contract health delivery area is overlapped with Cherokee Nation area. We work hand in hand on different counties. We've divided it up by counties usually, and they overlap. Between the two of us, yes, we cover most of the 14 counties. That's the simplest answer I can give you for that. If you really want to see that, come up and see me. Or see your contract health director. There's a multi-page book that on each county and each community. But yes, we cover those 14 counties.
Okay, thank you.
Okay, George. Appreciate
Thank you.
it. Thank you, George.
And for you guys that are new, I was going to tell you, you don't have to wait till here. If something comes up, one of your constituents, contacts you, text, email me, call me there at the hospital, and don't let issues lay out here. We don't want to delay care or taking care of anybody, so just holler at me.
George, would you mind giving that contact information to Gail? And she'll
Yes,
just
yes.
send out to all 17
will.
of us. Thank you, George. I assume there's Dr. Jones is here. Afternoon, Dr. Jones.
Well, I'll just jump right into it if that's okay. Is that okay?
Sure.
All right, so our report is in your packet. A lot of the same stuff that we report on each time. Our provider vacancy rate, 3.9%. The benchmark is 25%, so we're well under that. For those of you that are, this is your first health committee. I heard a question that you asked about contract health and the jurisdiction of. The jurisdiction of contract health is a geographical jurisdiction. It's called a CHISDA. It's an acronym for it. And whenever we have our orientation for the new counselors, and anybody that's on the council is welcome to come to that. As soon as we have those dates, we'll have our contract health senior director there, and he'll be glad to speak to you about that, show you on a map where the jurisdictions are and how they overlap, because we do work hand in hand with those folks that live in the Claremore jurisdiction and we overlap with. But it has to go through a different process than those that live outside of the Claremore district. So we will explain all that, and we can lay it all out, and you can ask questions and get a good understanding of it. So it is a complicated subject because there's inpatient and outpatient. It's split up a little differently. So, okay. Our referral approval rate, 96.2%, you can see there. And then if you look over on the next page, you can see our revenue. We're far ahead of where we were last year. Of course, we had shut down for quite a while last year, and so you can see that our revenue that we've generated is increasing quite a bit. And then on the last page, you can see, again, this is July's report, as George had reference to, so we're always running in the rears when we come to speak to you guys here. But you can see the vaccine and uptake by week has increased, and that last bar graph kind of exhibits that. Some of the things that are going on in our health system right now, we're working very hard on Medicaid expansion and reaching out to all the citizens that we can and get them enrolled. To date, and since the expansion has taken place, we've enrolled 5,572 citizens that were previously not enrolled. So we have 5,572 more citizens that have benefits for the whole Medicaid benefit package, not just health care. So we think that's worth doing, and we're continuing to do that every day. We're calling people and encouraging them to enroll and telling them about the benefits of enrolling. The COVID numbers, we'll talk about that just a little bit. In the hospital, we have currently 19 patients that are COVID positive. Of that number, 95% are unvaccinated. We have 5 ventilators running right now. I think last time I talked to you, we were at 7, so we've gone down a little bit, but we're still seeing those high numbers and high acuity every day. We continue to see high numbers in our urgent care and ER, and as a result, we're trying to take a little pressure off those folks on the weekends and do testing in our drive-thrus at Tahlequah to take those folks that would normally show up in the urgent care or ER to get tested. We do it through the drive-thru and take a little pressure off them, and we even did it on Labor Day this year. We set up and had the drive-thru working all day, so that was just to alleviate a little bit of pressure. We are continuing to do the monoclonal antibody. I think the last count, we've done more than anybody in the state, probably more than most of the state combined. We have it running at our CNOC here, our outpatient center here in Tahlequah, 6 days a week. We've expanded out to Bonita, Muskogee, and Salisaw, and we're doing those 5 days a week in those clinics. And it's very intensive on the way that we have to do it, so we're not able to get it into the smaller clinics yet because of staffing. But we are able to do it in some of the larger clinics. Testing, we're still averaging about 600 a day through our test facilities, and Our current test positivity rate is 17.6%, so it's still active and running strong in our communities. So we're still seeing the numbers come through. On our vaccine, we've given over 76,000 vaccines since we started this. The numbers have been increasing over the last 2 months as the Delta variant has taken more people have been ill, and more people that maybe that were a younger age with higher degrees of illness have inspired others to get vaccinated. So however it takes to get people vaccinated, we're in favor of getting people vaccinated. So we're working very hard to alleviate those hesitancies and make sure we get everybody vaccinated we can. Our Cherokee Nation staff is 75%, over 75% vaccinated. Statewide, I think they're at about 45%, so we're doing far better than the state in getting our workforce vaccinated. George mentioned flu vaccine, so we have received our flu vaccine. We've been working, putting together how we're going to do this because we're already short-staffed with all the other things that we have going on. So we've come up with a plan, and I want to go over this plan, and I want you guys to write it down, or if I can send it to you, out to you electronically, I'll send it to Gail and she can get it out. Currently, our plan is this week on the 15th through the 20th, 15th through the 17th, we're going to focus on our healthcare workers. We're going to get as many people vaccinated as we can in those days as we can possibly do. Then on the 20th, we will start doing outreach and vaccinating the communities. We're going to open up our testing drive-throughs on Monday, Wednesday, and Friday from 1 to 4, and on Tuesday and Thursday from 1 to 7. And they can drive through and get a vaccine, a flu vaccine. So we'll still do testing in the morning every day. If someone is sent to us through public health or other means that needs to be tested, we're going to send them into the clinic or to curbside, and we will still test them. We won't turn them away. But we're going to transition our vaccine, our testing drive-throughs into flu vaccine drive-throughs Monday, Wednesday, and Friday from 1 to 4, Tuesday and Thursday from 1 to 7. And that should catch those community members that are working, catch them right after work, and get as many people vaccinated as we can. Okay? So the next thing I want to address is something that's been on my mind quite a bit, and I brought a couple of people in to talk to this body here in a few minutes. So there's been quite a bit, I won't say quite a bit, there's been some irresponsible and inaccurate information that members or a member of this body has put out on social media. And to read that, I'm going to quote this so you know what that statement was. It says, "Vaccinated or unvaccinated, every citizen deserves the right to equal health care when sick." I have already heard many stories about sending unvaccinated citizens home when admitting vaccinated citizens. As you can tell from our numbers, 95% of our people in our hospital are unvaccinated. So that is absolutely inaccurate. It's irresponsible. You guys have a platform that you have a lot of influence in the communities, and it brings a sense of unconfidence or lack of confidence in our health system. If I was unvaccinated and I needed help, if I read that, I would think, I can't go to Hastings and get help. I have to find somewhere else to go. So I'm going to bring in a nurse and a doc that work on the front line, because I want you guys to hear from them how statements like this affect them and affect our community. So the two people I'm going to bring in is Michelle Marshall. She's currently the Tahlequah campus nurse manager. She has 22 years experience as a nurse, 10 years with Cherokee Nation, and she's a tribal citizen. I have Dr. Dustin Beck. He's a hospitalist. He cares for our most sick in the hospital and ICU. He has 8 years' experience with us as a doc, 11 years if you count his residency with us. And he's also a tribal citizen. So if you'll pleasure me for just a minute and let me, or indulge me for just a minute, I'm going to let them speak to you from their heart and let you guys hear how statements like that affect not only our citizens, but our healthcare team. Push the button.
Okay, thank you, sir. Is it already on? Okay, okay. As Dr. Jones introduced me, I'm Michelle Marshall. I'm a registered nurse, and I'm the Tahlequah campus nurse manager. The past year and a half of our healthcare staff's, of our healthcare staff's lives have been nothing short of a living nightmare. They work countless hours to care for the sick, those in need in our communities, regardless of a vaccination status, and most certainly regardless of a payer source. It is not about judgment. It's not about picking and choosing who you will help, because that would place subhuman value on others. That is not what the calling into the nursing profession is about. Nursing is about providing care to those in need when they are in the most vulnerable and fear-filled times in their life, and doing so with empathy beyond compare. Imagine the fear that grips a person when they are battling a severe illness. And I'm not just speaking of COVID. I'm speaking of everything from an asthma attack to devastating cancer battles to life-altering heart failure battles. Those who are dependent on hemodialysis for the rest of their lives. Those who have sustained a massive stroke who can no longer take care of themselves, feed themselves, or speak for themselves. Our nursing staff tend to these needs daily and do so to the best of their ability, all coming from a place of love and compassion. When we added more med-surg beds into our hospital and made adjustments to existing beds to provide critical care to more patients because we had nowhere else to send them, it was our staff who stepped up. When we added drive-through testing to meet the needs of our communities, again, it was our staff who stepped up, even in the blistering heat and in the coldest temperatures we've seen in over 10 years. When we added monoclonal antibody infusions to our COVID-19 treatment arsenal, again, it was our staff who stepped up. Our staff continued to step up. And tomorrow, they will do it the same again. They always step up for our citizens and even the populace that are not Native American. It was our staff who learned new skills, our staff who continued to work extra hours. It is our staff who hold the hands of our citizens who can't have visitors because we are in the middle of a pandemic. It is also our staff who step outside of a room and find a corner to cry because it is so overwhelming and heartbreaking. With those additional beds and all the other services we have added, also came the increased need for staff to take care of those patients. Every time that I have asked for the needed staff, I've always been met with, if that's what it takes, Michelle, then get the staff here. Along with these increase in patients also comes the increase for needed extra personal protective equipment, patient care equipment, supplies, etc. Never has a need went unmet. This is how the COVID relief funds have been appropriated throughout this pandemic, and I truly appreciate that from our healthcare executive leadership and our tribal administration. The amount of death and despair that our health system team has seen and continues to see is absolutely atrocious. When the second wave of COVID was coming, one of my nurses said it best: the physical battle we can handle, Michelle. It's the mental battle that's going to take a toll this time. Our staff are suffering tremendously with anxiety, depression, and PTSD. And all of those stem from the relations of the pandemic. When negative social media posts are made by elected officials regarding the efforts of our healthcare system team, it is a slap in the face. It's a slap in the face of a team who has worked tirelessly to provide for the needs of those that we have vowed to serve. We have to support one another during this time, because if we don't, we will lose many others to battles that no one else knows about until it's too late. We are better than this. We are stronger than this, and we are stronger together. Thank you.
Good afternoon. As Dr. Jones said, I'm Dr. Dustin Beck. I'm a hospitalist at Hastings here in Tahlequah. It's a position I've had. I'm starting my 8th year working at the hospital, but if you include residency, I've been there for 11 years. As a hospitalist, my responsibilities include doing admissions, hospital rounds, discharges, and providing consultation services to the other departments within our hospital and clinics. So I've been right on the front lines since the pandemic started. I was asked to come here today to talk a little bit about how the pandemic's affected me and my work colleagues, and then how those statements that have been alluded to, how that can affect the morale of us working on the front lines. For myself, just like everybody else who's dealt with the pandemic, it's been tough. Over the last year and a half, I've signed more death certificates than I had in my previous 6.5, 7 years combined, plus some. Many of those were older, and so you take COVID-19 out of the equation. You come in with a critical illness, and you're in your 60s or older, your survival chances start to go down. There's only so much your body can handle. But there's been more than a few that have been my age or younger. I just turned 38 a few months ago, and there's been some as young as in their 20s. And those bother me probably the most because I can relate to them more. And I think about all the things that they're not going to get to do or experience in their life. They're not going to get to become parents. If they were parents, they're not going to see their kids grow up, and so on and so on. So those probably bother me the worst. I know I've got some degree of post-traumatic stress already. When I'm not at the hospital, I help teach some classes at the medical school here in Tahlequah, and I found out the other day that the bell that the elevator makes, or the ding the elevator makes when it reaches your floor, has a very similar pitch to our code blue alarm at the hospital, which signals a cardiac or respiratory arrest. And so I was waiting on my elevator and not paying attention, and it went off, and I jumped a few inches off the ground, getting ready to get up and run somewhere, because that's just how I'm conditioned now. When I come home from work, I don't tend to talk about what I've seen that day. I tend to just try to leave everything at the hospital and try to forget about it. I don't know if that's the right decision or not, but that's how I've dealt with it, and we'll see in the long run what kind of effect that'll have on me. As Michelle mentioned, adding another layer to all of this is seeing how my work family has had to deal with this as well. And I mean family. We all care for each other at the hospital. That was something I noticed as a medical student on rotations. That's something I continue to see as a resident, as an attending. And it's not just relegated to myself with other physicians or the nursing staff with other nurses. We all care for each other. We're all one big family. And it's hard to watch your family struggle with the same things that you struggle with. I've heard of stories of them, crying on their way to work or from work because of what they were about to go and see, or what they had seen that particular shift, and then seeing them at times crying at work when we lose somebody unexpectedly, and they don't have time to grieve or process it or think about if there was something they could have done differently to prevent it, because they've got another load of patients that they're having to take care of that are in a very similar situation that could be the next one. And so without any other better way to explain it, we just have to shake it off and try to keep moving forward and try to forget about it. The morale right now is probably the lowest it's been in definitely the 8 years that I've been here, but maybe ever. During the first wave, there weren't any really great treatments. There weren't vaccines. Every day that we went to work, we were risking our health and potentially our lives to try to save others. We had I know for me, I had a renewed sense of passion and purpose for my profession that I entered. We were held in high regards. We worked together and for each other, trying to save as many people as we could. The vaccines came out, and we thought, okay, this is the beginning of the end. We'll get people vaccinated, and this will soon be over. But for various reasons, mistrust, miscommunication, misinformation, hesitancy, what have you, the vaccine rates have not been as high as we would have liked. And coming with that has been a second surge. And those feelings of passion and purpose and energy have been replaced with depression, burnout, fatigue, exhaustion. One thing that has helped us throughout this whole time, since the beginning, is having tribal leadership in our corner. We've said since the beginning that we were going to take feelings and politics and opinions off the table. We are going to guide our recommendations. We're going to guide our treatments based upon science and facts. And by and large, we've been able to do that. As Dr. Jones and Michelle both had mentioned, there had been some statements made here recently that seemed to kind of go against that. And I just want to try to clear up some of the misinformation that was in that post. It said that we had only had the same amount of beds from the beginning of the pandemic that we have now, and that number was 25. Going back, if you count the 2 years I was in medical school on rotations, we've never had 25 beds. We've had maybe 30, but never below 30. A few weeks ago, when I was the daytime hospitalist, I've been having to get up like an hour and a half early to go through all the patients, to make myself little notes on what the plan's going to be for that day because we've had so many. And every bed at that time was full, and we had 42 on our list. So definitely not 25. At that time, we had 42, and we have plans in the next few weeks to hopefully expand that even further so we can keep more patients here at the hospital. Like she mentioned, we can't send patients anywhere else. There's some nights where they'll call every hospital within a 500-mile radius looking for a bed for a COVID-19 patient, and there are none. And so they're having to be housed in our ER or wait till we can get somebody moved around or discharged upstairs to keep them here. A lot of times we're having to do things that we're not accustomed to doing, taking care of patients that are sicker than what we've had to care for in the past, but because there's no other options. Also kind of alluding to what they mentioned about the turning away unvaccinated patients for vaccinated patients. As I mentioned, right now, we have 95% of our patients in the hospital are unvaccinated. When I'm called for an admission, the information is given to me, I've put in orders, I've called and had them start getting a room ready. I don't know any of that. I don't know their vaccine status at that time until I go downstairs and start talking to them and ask them. And not because it's going to change what I'm going to do, it's just we use it for our statistics. We all in the healthcare profession, we're held to higher standards when it comes to professionalism and importantly from ethics. We all take oaths. We're to do no harm. We're going to take care of every patient regardless of age, sex, gender, race, ethnicity, vaccine status, what your favorite Oklahoma college sports team is, doesn't matter. If you come into our hospital, we're going to take care of you and give you the same treatments that we would give anybody else. To say that we would do anything other than that, whether it was intended or not, calls into question our ethics. And there are few things that will irritate or anger a healthcare professional more than to question their ethics. Many of us, and I'd be lying to you if I said that I hadn't thought about it from time to time myself, if another opportunity came up that didn't involve being right on the front lines of dealing with COVID-19, whether it's in healthcare or outside of healthcare. If that opportunity came about, would that be something I would take? And statements like that seem to call into question your motives and your ethics definitely are statements that can persuade that individual to maybe really consider that the next time something comes about. That's going to hurt us now while we're overwhelmed with patients. It's going to hurt us in the future when we hope to continue to add services and bed capacity and keep more and more of our patients here in Tahlequah. So in closing, I know many of you use social media to communicate to your constituents. As Dr. Jones said, I'm a constituent. I vote in the elections. I like to be informed, and that's a really easy way to do it. But I just respectfully would just ask that we try to keep the negative comments, in particular ones about the virus, our hospital, our healthcare system, and our healthcare professionals working there. Try to keep those off social media. Most of us are just hanging on by a thread, and any statement like that could be enough to cause us to want to leave. If you're going to put anything on there about it, put out praise and gratitude for those that are mustering up every ounce of courage and strength they have to get through that particular shift, because those statements go a long way with us as well. We thank you all for your leadership. We know that this is not something you're forced to do. That's not lost upon me. It's not lost upon any of us. We just hope that you'll continue to support us as we continue to fight this pandemic for as long as we have to. Thank you all.
Thank you all.
Thank you, Dr. Beck.
Thank you all.
Thank you, Ms. McGee. That's,
Dr. Dobbins,
yes,
before they leave, could you bring them back in?
we may have some questions for the.
Yes, sir.
Yeah.
Or comments,
Yeah.
sir?
Dr. Beck and Ms. Marshall, would you be open to some questions?
Yeah, sure.
Yes.
Okay, Julia?
Thank you.
Mine is not a question, but a comment. We have, Mary Baker Shaw and I, our former counselor, have hosted, I think at this time, about 4 town hall meetings with Dr. Gann and with Ms. Pivick. And at the end of every one of those meetings, we have said, please give our love and our respect and all of our regard, and how are our people in the hospitals doing? And they have spoken many times about the fortitude and the courage that is being displayed by everyone there. And I trust that they have done that they have conveyed our respect, and of all of the at-large constituents who have been on those town hall meetings as well. But in case not, I want to give it to you to take back and to give to all of your coworkers exactly that same message. We have nothing but the utmost of love for all of you and respect for everything that you are doing. I can't even imagine what you must be going through. And we love you.
Thank you, ma'am.
Thank you. We appreciate that.
Very much so.
Other questions? Melvina?
I don't have a question, but I'm kind of like Julia. Losing a family member, your work means a lot to me. But this is from non-Indian, outside people. Just in the last few weeks, told me their admiration, the work that Cherokee Nation has done in this battle against COVID. And it said compared to the other sector. So there's people out there that is non-Indian watching and praises you for what your work that y'all are doing. Thank you.
Thank
Thank
you,
you.
ma'am.
Wes?
Whenever last year's wave had happened, one of the ER doctors lives across the street from us. We'd see him, he works nights, and so he'd see him leaving at 7 o'clock, you'd see him pulling back in at 7 o'clock. And normally, I think he'd have a couple days off. I think it was Friday or Saturday or something, and you usually see him out there playing with his kids. But we kept our distance because, he was worried about catching it and then giving it to us and vice versa. And then, it went from those couple of days to where I never saw him. I never saw his truck coming back or leaving. He was working every day, all day, and the ER was just overstaffed. And I was looking to try to help them out. And, you know, we fed the ER doctors and the nurses there, and, because it's being in the district, but now, I mean, then we had a lot of the doctors and nurses helping out with the testing and trying to get the vaccinations when they first started out. Now, this wave just being different, it seems like all hands are on deck as far as just handling patients, just handling sick people. It's not just the ER doctors, it's everybody. And in fact, just the past few weeks, we've been trying to figure out how do you show gratitude to that many doctors, because it's just beyond the ER. So, you know, anything that Dr. Jones or the staff or this council would want to unifiedly try to show some sort of appreciation beyond just the words of thanks, it's something we could all definitely look at doing, because it definitely doesn't go unnoticed of everything that's going on from the amount of work that you guys are doing, from the staff that has left, from just the overall catastrophe that's going on in our healthcare, and the ones that have been able to stick through it. You know, hats off on to them for sure. So much appreciative. So thank you.
Thank you.
Thank you.
Diligent prayers is most appreciated.
Mike?
Well, the first thing I want to tell you is you are still held in high regard. Don't ever think that you're not. And don't ever think that you're not supported by this council. Even though some negative things came out, I promise you, this council supports you in what you do.
That is appreciated, sir.
Well, Wednesday, my son's wife was feeling a little sick and went to a place north of my town to get checked out. Stomach was hurting and was told that she had gas, and they wrote her a prescription. When she came home, it just started getting worse and worse and worse. So she was brought to Hastings Wednesday night and had emergency appendectomy done after you guys ran the tests. It was not done where she was taken the first time, and if she wouldn't have went, she very well possibly could have died if it would have ruptured. But when I was there, I had to go pick her up, and it was they let her go home that night after emergency surgery. And there was the first person who came in when I was there, had COVID symptoms, was not vaccinated, and they immediately took care of that person. There was no hesitation because they weren't vaccinated. They took him over and started their intake with him. And as I stood there, I always talk to nurses, doctors, whoever I can see, just to ask how things are going. And there was a nurse, because had been there 16 hours, had why are you there? Well, we had, there's been some illness, people just couldn't come in because they were sick and different things. She's on a 16-hour shift. So then I get to go down to pharmacy and talk to the pharmacist. Same story, long hours and just frazzled out. Everybody there answered every question that I asked, was more than happy to talk to me. I didn't tell them who I was or what I did on this council, but every one of them was up front with me about what their job was, how long they'd been there, how things were going, can we do anything different to make it better? I asked them those questions, and every one of them talked to me. But bottom line, and I think as all tribal council, we have to understand that what we say does carry some clout and some weight. So if we're going to put something out there, we need to have backing before we start popping off about things are this way or that, because it does affect people, and it's not right. Either you have proof this is the way it is, or you don't. We don't make things up. And I myself hate that you have to be here to defend yourself, because in the end, we are the ones who should be defending you for everything that you have done for our people. And I know I've talked to administration, I've talked to other councilmen, and we are very, very proud of what you've done for our people in our nation. Don't ever think that. You will always be in high regards to us. And I just want to say thank you.
Thank you.
Thank you.
That'll mean the world to our staff.
Candace?
I agree with everything that Speaker Shambaugh just stated. I would also like to state for the record that any irresponsible and inaccurate information should be withdrawn publicly in the same manner with which it was put forward. That our Cherokee Nation healthcare professionals deserve an apology. And I completely echo Speaker Shambaugh in saying you have the complete and total support of this body, that we should absolutely be the ones who are defending our healthcare professionals, because you are literally facing life and death on the front lines. You're putting yourselves at risk, and you're putting your families at risk to take care of ours and to take care of us. And so with deep, heartfelt gratitude, I say thank you for the jobs that you are doing. And I know you're here representative of your colleagues, and please express that to your colleagues as well, that we absolutely know how difficult it is to find good healthcare professionals, and we have some of the best here at Cherokee Nation, and we need to defend and value those individuals more.
Thank you, ma'am.
Well, thank you.
Okay, I guess we're done, Dr. Beck and Michelle.
Okay.
Thank you for coming.
Thank you.
Appreciate it very much.
Well, thank you guys for indulging me in that. I had several emails, phone calls, text, and of a lot of people wanting to come and address this body. That type of communication hits in the heart. And I take this job very seriously. I take it very personally. I tell our when we have orientation every week that I celebrate our victories, and I wear our failures personally. It wears heavy on me, to a point that I lose a lot of sleep trying to think about how we can lift the morale of people that are on this front line every day. Our team works every day to try to figure out what obstacles, what support we can give them. And no matter what we do, it's words sometimes that can really hurt the most, especially as Speaker Shambaugh had said, you guys carry a lot of weight. You're elected by your constituents to be their voice. And when they hear things from you guys, it can be uplifting and it can be devastating. So weigh your words carefully. We don't, in the healthcare system, do not want to be part of a political game. We're here to save lives and to take care of people. And again, thank you for indulging me in this and letting them come and speak to this body. So with that, I'll close out my statements.
Oh, no. Our elders that took the booster shot, then they're wanting to know how long they should wait before they take their flu shot. What do you recommend on that?
There's guidance coming out on that. I don't know that there's a time frame. We have our healthcare professionals researching it right now to see if there's any reason you couldn't take them both in the same day. If someone came in and wanted to get the COVID vaccine and wanted to get the flu vaccine, I was off on Friday, so I didn't get to communicate with Dr. Gray. He was doing the research on that, and I haven't got a chance to communicate with him this morning. But we'll get that information out, and I'll get it to you. But I don't know that there's anything wrong with taking it in a short period of time. We're just trying to figure out if it's okay to do it the same day. I don't know that there's any contraindication for a period of time there.
Okay. Will you make sure Gail sends us that
Yep,
schedule,
absolutely.
please?
Yep.
Thank you.
Yep.
Steve, Doctor, I appreciate you so much and your staff. Same question Councilor Dobbins had. Are we able to find out if it's the Delta variant yet through our facilities?
We do the same thing. We send cases to blood draws to the state, and the state is testing for that. I don't know how much of that's getting back to our public health team. They're keeping the stats on that. We've been told by our public health team when we have our morning huddles that when you have COVID, assume it's the Delta variant, because it's so prevalent in our area that it would be a rarity not to have the Delta variant. So the assumption is we have the Delta variant. Yeah.
Yeah, Dr. Jones, part of being a counselor here and trying to address the situations that come up in healthcare is a difficult thing at times. I'm sure you're well aware of that because you run the health facility. But I've spoke to a lot of different nurses and doctors addressing, complaints that they've called with or the direction of how to possibly better proceed with making the hospital that much more capable to combat these COVID waves. And the one thing that kept coming up, which was last month's questions, was about the bed, and that we had a lot of these funds there to kind of convert situations or where we could do to look at it. When those questions were being asked to you, they were being asked and directed in a way to try to get some sort of what could we do to better improve the healthcare through this pandemic. As the funds are readily there available, one is, like I suggested, we have nurse practitioners that there's a plethora of, could we hire them? And there was a lot of brainstorming trying to get that involved. It's just a concern, whenever we have this rise that we've had in this COVID wave, and then we've seen a lot of money get spent from this administration on other things besides healthcare, whenever the healthcare was the intended purpose for all the money coming in. So yeah, I have concerns about it. I have concerns about where we spend the money, how we're converting to new healthcare beds, not converting a nurse's changing room or whatever to a bed, or how could we convert situations to where we could have more beds up there, or what's going on, how could we fund it better? Those are the things that, as a counselor, I'm trying to get from you as an administrator, because that's our job, is to appropriate funds and create laws. How could we get more accessible funds in your care? How could, as an administrator, you get more? Is it more money? Is it this? Those are the questions that I ask you to try to help out with the problem from this pandemic wave that's come through and now is on all of our employees and stuff that are up there. So that's the way that I've addressed things coming from my position as a counselor as a concern. There's many, like I said, doctors and nurses that I speak with that I've called and conversed with. They're trying to ask, hey, what if we had this? What if we had that? I'm not a healthcare professional. Help me learn. Help me try to understand where could we make improvements as maybe a counselor, that I could bring something forward to make those changes. Those are the things that I come from as a counselor standpoint. And, I appreciate the doctors coming in and expressing their concerns about what people have said on social media. It is just a concern overall of what we're going through in this pandemic. So that's just kind of the statement I had about this. And like I said, worried about the health care and the citizens are receiving, worried about good doctors and contracts that don't get renewed, possibly, having a big amount of patients that, a doctor may have for a while when they don't get their contract renewed. What do those patients do? Do they just fall over into a new care doctor? Is that how they happen whenever their current provider or their surgeon produces surgeries on them, and then they have a schedule, say next month, if I've got a scheduled surgery with a doctor I've already had surgery with before, and then they leave, what happens to that patient?
So where would you like me to start? That's a long statement.
Most of it was statements. The last one was just a question.
Let me start with the beginning. If you don't think we're not looking at every option that we look at every single day to try to find more ways to keep our patients at home, then you're mistaken. We do that every week. We look at how can we keep patients closer to home. It's not as simple as buying a hospital bed and sticking it in the hallway and saying there's another bed to put a patient in. There are life safety areas in the hospital that you can legally put a patient bed in. There are areas you cannot put a patient bed in, because if you had a fire or you had an emergency, you have to be able to get that incapacitated patient out of the hospital into a safety zone. There are all kinds of rules that go along with other than buying a bed and sticking it in a corner. There are monitors, there's equipment, there's staff. All that has to be coordinated. It's not as simple as just giving us money and doing it. And then you got to think about everybody in the nation's trying to do this. So even though you may have the money to buy that equipment, it may not be available to you because the manufacturer doesn't have it. They've shut down because of COVID and they haven't manufactured it. So we are trying to anticipate every move way ahead and try to purchase stuff that we know we're going to need. We've updated every one of our beds to universal beds so we can raise the level of acuity as the patients need it. We have to train our staff because, as she said, they're doing things that they have not been trained to do because they were used to doing this level of acuity and now they're having to do this level. There's competencies, there's training, all that stuff has to be coordinated. It's not as simple as flipping a switch. And if you can find me nurse practitioners that are willing to work as RNs, we'll take them. They're not willing to do it. They went to school to be a nurse practitioner, not to be an RN. They're not going to step down and do that level of work. It is impossible to find those people. But I haven't heard from you when you said you've talked to people about ways to do things better. I haven't got an email. I haven't got a phone call. It's statements like that that lead people down a road that says that we're not trying. So communicate with me. I'm the person that you need to communicate with to get that information out. I will communicate back with you. Every single person on this council can verify that.
Yeah, I know that, and I will converse with you. It's just that I have friends that are doctors. I have nurses that pick up cookies from my wife.
Okay, and
So
you're saying they've
these are
told you
people
things we
that
could do better, but you have not communicated that to me.
These are people that I've talked with, and it's concerned. I did talk with you last month when you came in. I said, well, could we do that? And I'm just brainstorming. No one should be criticized for brainstorming. I'm not a healthcare profession. You are.
Right, but
So I asked you,
brainstorming
how
in
could we do
public
these
and
things?
throwing out
Well,
ideas that aren't possible are dangerous.
it's not that they're not possible, that they're dangerous. I'm just making suggestions. Like I said, I don't know. I'm here as a counselor trying to help out a situation. That's all I've tried to come here to do,
Okay.
is ask questions from you. Hey, could we look at this or how? And I'm not saying that you haven't already looked at it. It's just that's me trying to get educated and also think of ideas of how we could help out. But I mean, if that's I mean, I know that you work with administration back and forth to try to get these things done. I just want to offer my helping hand whenever I ask those questions. That's all that is. So, appreciate
Dr.
it.
Jones, do you care to respond further?
No, I'm good.
Okay. Any other questions for Dr. Jones? Oh, Julia, sorry, go ahead.
Well, I share some of Counselor No Fire's concerns, actually, my concerns, because I understand the financial difficulties right now because you've been sharing them with us at these meetings every month, right, about the need for, we can't just throw a bed in there because we've got to have staff, as well. Every new bed we put in there, is a larger load on the staff that we have. At some point, we've got to have more. How can we attract that? We're racking our brains to figure that out. Where's it going to come from? We've got to be competitive. I've been hearing all of these messages, for months and months, and I understand and I believe because I work for a health system out in California that's the same thing there, so I get all of that. But I also just have concerns about the loss of personnel as well, personnel that we already have, And I just wonder if you can address that a little bit, and if you can share with us, what do medical staff, what kinds of expectations can they have in terms of job security here? I guess how do already existing staff factor into financial decisions that are made? And just speak in kind of general terms about that to again, help me, and I'm sure all of us, to understand what the considerations are here, as we find ourselves in this rather unique moment in many respects.
Sure. And, one of the things we do is we work with a lot of temp services to try to fill gaps where we have gaps. It's a simple supply and demand issue. There was already a shortage of nurses before the pandemic ever came. We were already talking about this a year before the pandemic got here, that there is going to be more nurses retiring than coming out of school. We need to start planning for how we can keep nurses in our area. We started down a a educational program with Northeastern and with Connors to have a bridge program to put more nurses in our community. We worked with Northeastern Health Systems to have a partnership to do that, and we helped fund some academic positions to be able to expand their classes. So we were already working on that before this hit. When this hits and the supply and demand get way out of the ratio, now you have these temp companies, we call them, our slang terms, headhunter companies, and they come in and they start recruiting. And they will actually pay people to break their contracts and pay them an exorbitant amount of money to leave this system and go over here to this system. Now, in our system, we can't react that fast. We have to work through processes because we're very large, and we have rules because there are rules tied to the type of funding that we have on how we work through those things. So we're not as reactive. We're trying to come up with ways to be more reactive, but it's a difficult situation because we are a government entity. As we adjust, they keep adjusting. So they keep raising the rate. And what's going to end up happening at the end of the day, and this is these people are making a lot of money right now, at some point it's going to catch up, or this is going to be over, and all this is going to drop, and these people that are out here that got pulled away for a 3-month contract or a 4-month contract are going to be left leaving a job they had security with to go over here and work for 3 months, and then all of a sudden there's not that job's filled because someone else came in and took it, and we've trained somebody now in that position. So we are looking at a lot of different ways to be, I won't say reactive, we're trying to combat that. We realize that's happening, but it's being pivotal as fast as we can is a little bit difficult in the government organization.
May I follow up with, yeah. What about, okay, so you're speaking about nurses and nursing, and I understand that is the critical area of shortage right now, and what about at other positions? What at the level of physicians? What about at the level of surgeons? Are we having financial difficulties with, are people leaving at those levels as well for the same reasons? What might be going on there?
Not that I'm aware of. You can see our vacancy rate. If you flip back over, we're at a very low vacancy rate. So we do not have a lot of issues with turnover in our provider range.
Okay, so we are not in the place where we're not renewing contracts with physicians and surgeons right now.
Well, now I won't say we won't renew. Mm-hmm. Every year, we are all on contract. I'm on contract. Mm-hmm. Every year, I have our medical directors. They come together, and they look at all of the providers. And they look at them, and they evaluate them. And then they make recommendations as medical directors to our executive medical director, who then brings it to us as an administration, and we vet those decisions. And we look at weighing out the pros and the cons, what's the history, what's going on, what's caused this to, there's a variety of things. We don't look at just one thing. We look at a very well-rounded history of everything that goes on and how that person interacts with their patients, are there complaints against them, and how that person interacts with their staff, how that person interacts with the administration, us, how they communicate with us, how they communicate with their medical director, how they, what's their work ethic like. It's a well-rounded evaluation, just like we're all subject to every year. We all have evaluations done on us. And then determinations are made on whether or not we continue moving forward or we don't continue to move forward. Now, that's in a non-disciplinary way. There are other actions that we take from time to time where someone goes before a peer review board that's made up of peers, of medical directors, and they will look at someone's caseload, and they can make a decision on whether or not that person should be credentialed or privileged in Cherokee Nation. And if they choose to take away those privileges, then that automatically ends the contract because you cannot work in our system. So there's different ways that things can happen, but providers are held accountable, just like every other person in Cherokee Nation is held accountable. And that's the way decisions are made. They're not unilateral decisions based on one thing or two things. They're very well-rounded and well-thought-out decisions that are made.
Okay. So back to my original question about job security then, at the level of physicians and surgeons, for example, then job security is basically on an annual, year-by-year contract renewal basis, and that's it, so.
That's the standard, the gold standard across the nation.
Okay.
Anywhere you go to work, you're going to be on a year contract. And we measure that the way that we look at production, and that's a different subject, but we look at productivity, is based on something called the MGMA standard. It's nationwide and it's even broke down to regional. And we look at that standard and we measure ourselves against that standard. So if there's an issue, then we address those issues. But we hold everyone accountable. We don't want someone to come in and see 3 patients a day and provider B over here seeing 20 patients a day, but they're making the same pay.
Mm-hmm.
With MGMA, it allows us to say, if you're going to work at this level, we're going to pay you this much. If you're going to work at this level, we're going to pay you this much. And so every year, that is looked at, and that's decided on when their contracts come renew.
Okay. So are we hypothetically in any, those kinds of considerations ever place us in the position where we could be losing or closing down certain kinds of specializations as a result?
No, we would never do that.
Okay.
That would have to be a very extreme situation before something like that would happen. I think that has happened in the past. We did have a provider several years ago that was very specialized in a cardiology position that had a very narrow specialty, and they tried to build a service line around that person, and it didn't work out, and that person went on to a metropolitan area, and so that has happened in the past, but that's been 4 or 5 years ago, I think, when that had happened.
Okay.
So I won't say it never happens. I know of one time when it did happen, so.
Yeah. Okay. Yeah, I think so. Thank you, Dr. Jones.
Doc, are we having a difficult time hiring Cherokee RNs, or are we having a hard time hiring anybody RN?
It's just anybody. I mean,
Okay.
there's just not a lot of RNs out there that are available. And we do try to recruit some of our temporary services or these staffing RNs that come in. If it's someone that really fits into our system well, gets along with our staff well, we try to recruit them into our system to come on permanently. It's just a really difficult environment right now because it's, again, the salaries are getting way up there where they make a lot of money real quick, but at some point, just like everything else, it's going to go over the edge, and when it does, there's going to be a lot of people looking for jobs, but right now, it's very, very difficult.
Dr. Jones, I appreciate very much you bringing the staff with you today. I wholly regret the fact that you needed to. I regret the fact that they were distracted from their core job of taking care of our patients and taking care of our people to come in here and have to reset the political environment. That's really distressing, the fact that a political statement created a need to distract them from their actual job of caring for the patients. I regret that. I regret that. I suspect that this body regrets that. My parents, when I was growing up, heck, my mom still would do it, but if I was to make a statement that had this kind of negative effect, she would pull me by the ear and tell me I had responsibility to own my statement and make my statement right. And I hope something good comes out of this, because we should never be pulling our precious resources away from dealing with the patients to deal with political theater anymore. Thank you for you. Thank you for all you do.
Thank you. Appreciate that.
Thank you for visiting with us this afternoon, Dr. Jones, and thank you for your comments on the contracting process. I had some specific concerns that were brought forth to me from a citizen about the contracting process and how it is affecting them individually. However, I will visit with you later on those specifics, as we are precluded from discussing personnel issues or individual citizens within this particular forum. However, I do have one general question that is a bit of a follow-up from Dr. Coates' questions. And that question on the contract process is about continuity of care. So my understanding is, from what you've indicated, is that there will be continuing continuity of care for individuals who are being served by a doctor who is no longer going to have a relationship with Cherokee Nation Health Systems. Could you speak a little bit more to that continuity of care concern and how Cherokee Nation Health Systems addresses that?
So when a medical provider brings, or a medical director brings someone's name forward and has a summary of why they want to put this person's name forward, the first question that Dr. Montgomery and I ask, how are you going to take care of their patients? First question. All the other stuff goes away. How are their patients going to be cared for? And then when that answer comes back, then we move to step 2. But that is the first thing. Patients come first in this system. That's been our mantra since I've been in here. You can ask our staff. If you do what's right by the patient, you're doing the right thing. And that's the thing that we try to do every day.
All right, thank you very much, Dr. Jones, and I will follow up with you on the other issue.
All right.
Are we finished, Dr. Jones? On the way out, do we still have a shortage of rapid tests?
So there was a shortage of rapid tests. We're doing them currently right now. We got a shipment of rapid tests that had a short expiration date. They expire, I believe, next week. So we were able to find somebody that had an excess of those that they weren't going to be able to use, and we brought those in, and we've been able to fire up our rapid tests again. We have allocations coming. Evidently, what we found out is that when COVID started falling down in the numbers back in the early summer, that Abbott had shut down some of their manufacturing lines and switched them over to flu test, and so they were short on, and then when it started ramping up, because the Delta variant was so contagious, it ramped up very quickly. They weren't ready, and their supply chain got disrupted. So we're told that their supply chain, their lines are back up and running. We're getting allocations. We're asking for allocations every week from them, and they are giving us percentages of allocations, and we think we're going to be okay to get through, should we not, unless we have another big surge. But yes, we're back to doing rapid tests. So that's a long way of saying yes, we're doing rapid tests, but to give you a little idea of what we deal with, some of these things are way out of our control. We try to plan as much as we can, and we still sometimes get caught with things that we had no idea.
Okay, thank you, Dr. Jones. I believe we're done. Thank you.
All right, thank you.
Before we move into, I have a couple of announcements, but you may have gotten in your packet a written report from Cherokee Elder Care. The Cherokee Elder Care in the past has been reporting to this committee, but in reality, they're supposed to be reporting another way, and we're going to try to get that addressed. But their written report is on page 14 of the Health Committee report, and it actually states on page 15 there to report through finance, not health. I don't know what finance is, and there's contact information on page 17. Announcements, well, first of all, no old business, no new business. I have a couple announcements. Our OSU School of Medicine at Cherokee Nation, the dean has retired, Dr. Pettit, and they currently have an interim dean, Dr. Natasha Bray is the interim dean, but they are doing a search for the permanent dean at our medical school here in Tahlequah. And you might note that that our next scheduled meeting, it says, is next Tuesday, October 12th, is a Tuesday. We have them on Tuesday only when our Monday meeting falls on a holiday, and that's Indigenous Day. And starting next month, I'm going to ask that we bring public health in with health every month And because in the past, public health has come in every other month, and so we have 60 days between reports, and with the pandemic, the information is so fluid. I thought, let's bring public health in on a monthly basis. So starting in the October meeting, we'll start health at 12:30 and have public health there as well. And public health will be meeting with health on a monthly basis until we get through this pandemic. Hopefully that's agreeable. It might affect our lunch a little bit. Is that okay? Yeah. Okay. All right. Any other announcements? I would entertain a motion to adjourn. Second? Everybody agrees, I assume. Meeting's adjourned.